Good afternoon, everyone, and thank you for joining the Saturday presentations of the 2021 Biomedica Oncology Summit. My name is Ben Pfeiffer and I'm coming from Switzerland. Today, I would like to present our integrative treatment approach for patients with metastatic breast and prostate cancer. We all know that cancer incidence in the world is increasing from year to year. Last year in 2020, we had about 20 million new cases of cancer in the world. And of those patients, almost 10 million died. Now, your country, Australia, has a very peculiar situation in this statistic. You are having the highest cancer incidence in the world. There are about 500 new cases in 100,000 persons every year in Australia. Most common are breast and prostate cancer, followed by colorectal cancer, melanoma, and lung cancer. Of your 150,000 new cases diagnosed per year, about 50,000 patients with cancer die. A bit more than one half of all cancer patients in Australia will survive more than 5 years. 1 in 2 people in Australia born after 1960 will be diagnosed with some form of cancer during their lifetime. And it is 1 in 7 women and 1 in 5 to 6 men who will either get breast cancer or prostate cancer in their lifetime. When we look at the development of breast and prostate cancer, we can find many parallels. Usually, the cancer to become clinically relevant will need about 3 to 5 years, some say even more, up to 10 years to develop. The starting point is usually one transformed cell or a small cell clone that is not following the normal rules of apoptosis, meaning normal cell death, according to the suicide program. Those clones then get bigger and form a small cancerous growth. This growth is then often hormone dependent, meaning it needs a driving hormone to start cell division. With breast cancer, it's estrogens and progesterones, and with prostate cancer, it's testosterone and dihydrotestosterone. When those cancer cells get bigger and bigger, they invade surrounding tissues, they invade lymphatic vessels and blood vessels, and the disease becomes metastatic. This slide will show some breast cancer facts. The cause is widely unknown. We know that there's several risk factors. Dietary and environmental factors also play a role. Aging seems to be one of the major risk factors. In Europe, breast cancer is the most frequent cancer in women, with 580,000 cases registered in 2020. In Australia, this was about 19,000 cases registered in last year. Looking at the worldwide numbers, 2,300,000 new cases were registered in 2020, with 685,000 deaths. So you can imagine that the human suffering and economical burden for society are immense with this cancer. The symptoms are usually a palpable lump, either in the breast or in the armpit, skin irritation or skin dimpling, breast nipple retraction. Breast nipple can also be painful, sometimes discharge from the breast nipple. And if the disease is metastatic, there might be bone pain or abdominal pain if the metastases are in the liver. The diagnosis is usually made by biopsy, either fine needle biopsy or biopsy after lumpectomy. The treatment then is lumpectomy, more often so than radical mastectomy, and often lumpectomy and mastectomy are followed by either adjuvant radiation or adjuvant chemotherapy, or even both. Palliative situation is done with anti-hormonal therapy, and all these treatments are considered gold standard, but we know they have a high failure rate. 45% of all patients with breast cancer after receiving standard treatment are coming back with disease recurrence. There are also some experimental treatments out there, in particular HIFU, high intensity focused ultrasound, IRE, irreversible electroporation, and hypothermia play a role, but none of these methods are perfect, and they are not considered standard of care today. Looking at some breast cancer facts that you can take with you as take-home message, so to speak, we know that 10 to 15% of all women who are diagnosed with breast cancer come in an advanced stage of the disease. They are so-called de novo metastatic. About 40% of breast cancer patients will advance to metastatic disease despite of all curative treatment. 15% of breast cancer patients develop so-called late recurrence. These are recurrent diseases that can come after 5, 10, 15, even 20 years after initial curative treatment. About 80% of all breast cancer patients have hormone-sensitive disease. That means their tumor is responding to anti-hormonal treatment, either in the adjuvant or in the palliative situation. And we know that all patients on palliative hormone therapy will eventually develop treatment failure and not respond to the anti-hormonal treatment methods. Today, there are plenty of treatment options for metastatic breast cancer. The mainstay are probably chemotherapy and hormonal treatments. And under the hormonal treatments, we have hormone ablation, in particular for women who are diagnosed premenopausal, then also hormone blockade with aromatase inhibitors and SERMs, tamoxifen, toromifin in pre- and postmenopausal situation, and then the pure antiestrogens, Faslodex, which is mainly used postmenopausal. We have also a small group of patients who might benefit from checkpoint inhibitors and other immune therapies. Then chemotherapy in the palliative and adjuvant situation is standard of treatment today. And we have a bone protection treatment plan with biphosphonates, denosumab, and also radioactive isotopes like samarium, radium. And finally, I present to you today our own protocol with detoxification, phytotherapy, Immun-Support, anti-angiogenesis, antioxidation, and anti-inflammation. We have practiced this and modified these protocols for our female patients during the last 15 years and achieved good results for patients with time gain and good quality of life, which I want to present to you today. Looking at prostate cancer in a similar way to breast cancer, the cause is unknown. Diet and environmental factors play a role here too. Aging, again, is a major risk factor. In Europe, we have about 500,000 cases in 2020. In Australia, it was about 17,000 cases last year. And worldwide, there's about 1,300,000 new cases, and close to 400,000 men die from this disease every year. Again, the economical burden for society is immense. $15 billion alone in 2020 in the United States. The symptoms for prostate cancer are often very late, voiding and irritation problems can occur that are seen and compared to symptoms for BPH. There might be bone pain, but not every patient who has bone metastases has pain in those bones. The diagnosis here also is done with multiple biopsies, either perineal or transrectal, and the treatments today as a gold standard are radical prostatectomy and irradiation treatments. But again, quite similar to breast cancer, there's a high failure rate, meaning patients who consider them cured will see PSA recurrence at a high rate, up to 50%. Many experimental treatments are also available here. Again, HIFU or IRE, irreversible electroporation and hypothermia treatments, and even embolization of the prostate that has tumorous growth has been tried. But again, just like for breast cancer, none of those is perfect. Some facts to take home: about 20% of all prostate cancer patients are diagnosed with advanced disease. That means they are already metastasized when they know they have prostate cancer. 45 to 50% of all patients with prostate cancer will advance to metastatic disease despite curative treatments. And 100% of those patients will receive hormone ablation therapy. All of those will develop what is called castration-resistant disease, which was formerly also called hormone-refractory prostate cancer. Now, the treatment options are quite similar to what we have already seen for breast cancer. Again, hormone ablation is the mainstay at the beginning of the recurrent tumor or in the beginning of a patient who is diagnosed with metastatic disease already. And again, I have put some prices under these treatment modalities for your reference. Immune therapy, second line, hormonal therapy, chemotherapy, bone protection program, and again also our own protocols are collectively the treatment options for a patient today. With our protocol for prostate cancer, we usually see about 1,000 patients a year from all over the world, and we see them with stage 4 disease when they have done most of the other treatments for metastatic disease already. The survival of breast and prostate cancer depends clearly on disease stage. While stage 1 has a very good 5-year survival of 80 to 90, even 95% is reported. Stage 4, the survival is much, much less, and often less than 10% of the patients survive 5 years with stage 4 disease. The improvement of disease-specific survival with conventional treatments alone is usually measured in months. Metastatic breast and prostate cancer, for example, with multiple bone lesions, they can expect a 1-year survival of about 40 to 45%, but 5-year survival is often less than 10%. The big question here really is, can we do better than that? Yes, I think we can. And the next slides hopefully show you that it is possible to achieve more. This is our integrative approach for both cancer entities, breast and prostate cancer. We like to point out that it is important to use leading-edge conventional treatment therapies, meaning I'm not refusing surgical means, I'm not refusing radiation treatment, I'm not refusing chemotherapy if it needs to be done for a fast-growing triple-negative breast cancer. However, I always add other modalities that can either decrease side effects of leading-edge conventional therapies, but also improve outcome. And those methods are including dietary intervention, physical exercise, psycho-oncological therapies. They will include antioxidation, anti-inflammation, anti-angiogenesis treatments. They will also include immune modulation and support where it is needed, and detoxification. And finally, specific phytotherapy that we have developed for both cancers and that have been proven effective in those cancer entities. Everything with the goal of long-term cancer control, improving quality of life of those metastatic patients, and if possible, prolong their life on Earth. The first couple of slides will deal with our program Dietary Interventions and Detoxification. It is estimated that 70 to 80, some say even 90% of all cancers are caused by environmental factors, with petrochemical toxins and heavy metals being the biggest culprits. Wrong lifestyle choices, smoking, heavy drinking, recreational drugs, and lasting negative stress are certainly important to avoid for patients with metastatic disease or patients who have just received conventional curative treatment. You must get rid of those risk factors for recurrence. Bad nutrition, that means food without nutritional value, needs to be avoided. Our simple program is listed here below. We recommend daily hydration with over 2 liters of ionized water, pH of 8 to 9, instead of the normal tap water that comes up with 6.5 to 7. Reduction of animal fats and more fresh vegetables and fruits. You see very simple regimens. Reduction of caloric intake. The goal is normal weight. Certainly avoiding obesity. Intravenous chelation therapy to reduce heavy metals. And in certain cases, in certain patients, we recommend cyclic detoxification therapy with an activated zeolite. I talk about this product in a little bit. Some patients are also recommended to switch to ketogenic diet, in particular if two parameters are found to be increased in their blood. One of those is APO10, an apoptosis parameter, and the other one is a enzyme of the carbohydrate pathway in the cells called transcatolase. This slide shows you detoxification with detoxme. This is a zeolite product that has also green tea extract included. The raw material is volcanic rock that is tribomechanically broken down to almost nanoparticle. In that process, particles increase their surface area majorly, and they take on biological properties. Tribomechanically activated zeolite is a strong ion exchanger. It has strong detoxifying and antioxidative and even immune modulating effects. Green tea extract is added after the micronization, and the pictures here below show you the zeolite, how it's broken down to almost nanoparticle. This scale shows you 100 micrometer size. The manufactured product is a corporational effort from Aeskulap, where I come from, and a company in Switzerland that is called SwissTech. This is a spin-off of the MIT of Switzerland, a major science institute called ETH Zurich. The ETH has shown us that this product can remove heavy metals like lead, cadmium, mercury, nickel, and arsenic. It can remove aflatoxins from the gastrointestinal tract. Various pesticides are caught by the product and herbicides. It can also remove radioactive nuclides such as strontium and cesium. That's why the raw material was also dumped over Chernobyl and Fukushima to contain radiation from the reactor accidents. It attracts and buffers excess protons and activates macrophages, stimulates B cells, T cells, and NK cells. Now we use this product in a cyclical fashion for almost all cancer patients. And cyclical means they will be on one sachet of 9.5 gram per day for about 1 to 2 months, and then there's 1 to 2 months off period. If we look at the next step of our protocols, that will be antioxidation, anti-inflammation, phytotherapy, and anti-angiogenesis. I will introduce some of the compounds that we are using. PREVENTAN, for example, is recommended to our patients who have high risk of breast cancer to develop. That is containing indole 3-carbinol, resveratrol, quercetin, and the rest of those listed here. We recommend it to patients who have family members, mother or sister, that already have been diagnosed with breast cancer, or to those patients who have certain gene anomalies, BRCA1 and BRCA2, or ladies who have worries about uterine or cervical cancer, and patients who have family members with ovarian cancer. IMUPROS is basically the counterpart of this PREVENTAN for the male. It is an orthomolecular preparation with antioxidative and anti-inflammatory effects. It is manufactured with special galenic technology, which is called time-release tablets. This is done to prevent the various compounds from chemical interference with each other in the gut. So these compounds are released at certain times when the tablet is taken. Here you see the ingredients and their respective concentration in the tablet. And what we have done with this product that is manufactured by a small company in Holland called MedPro, we have used it for prevention of prostate cancer and even BPH with good success, and that can be done by 1 tablet a day. We have used it in chemo prevention of prostate cancer for high-risk men, and then 1 to 2 tablets is given, and we give it to patients who have established prostatitis and prostate cancer in a concentration of 2 to 3 tablets per day. This slide shows our phytotherapy compounds for patients with metastatic breast and prostate cancer. On the left-hand side, you see indole 3-carbinol and PREVENTAN as the main players for breast cancer patients. On the right-hand side, it's ProstaSol, Aeskulap cytosterol mix, and Prostectan for prostate cancer patients. And in the middle, we have several compounds that we use for either one, but also for patients with other metastatic disease, for example, colon, lung, pancreatic cancer. The middle column shows you curcumin as a representative of anti-inflammatory effects, artemisinin as a representative of own anti-cancer effects, convolvulus arvensis as anti-angiogenesis effect representative. IMUSAN is a Chinese traditional medicine compound which consists of 13 medicinal herb extracts combined in 1 capsule. MCP is modified citrospectin, and BioBran is an arabinoxalan compound, which I will explain later, that has strong effects on NK cells. Looking at the compounds that we use, they're all made by a small company in Holland, as I mentioned before. Why do we use a small company for that? It has reasons. Because this company has worked with us for 20 years. We are trusting that what's on the label is in the product. And we are also receiving yearly updates on their raw material that goes into the products and the certificates of analysis of these raw materials. So we are rather confident that we get what our patients pay for and what they need. This is indole 3-carbinol, and we know that it contains 200 milligram of indole 3-carbinol, 5 milligram of resveratrol, and a small amount of vitamin B12 per capsule. Indole 3-carbinol increases turnover of estradiol to estriol, a much weaker estrogen that inhibits growth of breast and prostate cancer. The compound increases apoptosis, that means the normal cell death in breast cancer cells. It inhibits prostate and breast cancer cell growth through interference with signal transduction, and it shows efficacy in hormone-independent prostate and breast cancer. And that is for us the most important effect of indole 3-carbinol, that it is indeed effective in those hormone-independent cells as well. The recommended dose is 400 to 600 milligram per day. This is ProstaSol, which we use exclusively for prostate cancer. It contains extracts of 9 medicinal herbs, which are combined with linum life. These are lignans and biocurcumin, and the biocurcumin complex that goes into ProstaSol has been shown to be highly absorbable and containing a high amount of curcuminoids that are important for the effects that we want to see. ProstaSol has been shown to inhibit cancer growth, reduces PSA, and reduces metastatic pain. It is also efficacious in castration-resistant prostate cancer. This slide shows us some experimental and clinical results with ProstaSol. It has become clear that ProstaSol will inhibit cancer growth in a dose-dependent manner. It will downregulate PSA expression and androgen receptor activity, and it has been shown to sensitize prostate cancer cells to heat treatment and radiation treatment. Below here you can see the bibliography for those experimental and clinical results. Curcumin we use for both cancers, breast and prostate, and as I mentioned earlier, for many other cancer patients with metastatic disease as an antioxidant. We know today that this turmeric-derived yellow powder contains a huge amount of curcuminoid A. In Curcumin Combi extra forte, there is an amount of resveratrol and quercetin that combines with the effects of biocurcumin BCM95. In the PubMed, you will find more than 5,000 articles confirming to the inhibiting effect of curcumin on cancer development and on cancer growth. You will find 500 articles about its anti-inflammatory effects, and you will find more than 10 articles on curcumin's angiogenetic inhibiting effects. All in all, we use this product for most of our patients at a daily dose of 3 to 4 capsules. Some patients even take 5 to 6 capsules a day without experiencing any side effects. Artemisinin is derived from Artemisia annua, sweet wormwood, and it has in itself significant anti-cancer effect. We all know it from its anti-malarial efficacy. Here again, there is plenty of evidence in PubMed for anti-cancer effects, over 350 articles published. There is over 100 articles about its anti-inflammatory effects, and over 50 articles describe downregulation of angiogenesis. IMUSAN deserves some explanation to you. There's 15 herbal extracts with antioxidation effects, with anti-inflammatory effects, with immune system modulating effects. And it has been shown in some publication that IMUSAN will inhibit cancer cell division in vitro. It inhibits oncogene IGF-2 in liver cancer. It normalizes a oncogene P53, and it increases activity of NK cell and other immune cells. Here below you find an article that has been describing these effects of this compound. Looking at immune modulation and immune support, for our integrative treatment approach, will describe the use of BioBran, our dendritic cell vaccine program, and second vaccine program that we started about 3 years ago with designer peptides. I first want to speak a bit about BioBran, which is today the strongest NK cell stimulator available. It comes in either tablet form or in sachet form as powder, and there are more than 30 peer-reviewed articles written and published about this compound in the US National Library of Medicine. When you compare BioBran with other arabinoxalans, then you can see that it has close to 4 times better effect than arabinoxalan B, and 3 times better effect than control when it is compared in its NK stimulatory effect. This slide shows you how BioBran stimulates NK function in patients with metastatic prostate cancer. And we have here 15 curves. One is almost flat and parallel over time, and that is of a patient who died at week 8. He would not show any increase in his NK cell function over time with BioBran treatment. All others, you see clearly, had increases over 50, 70, 100, 200% of their NK cell function, and also a much longer survival time. This slide shows you a large experiment in stage 3 and 4 cancer patients, not breast and prostate, but a mix of cancer patients with progressive and metastatic disease after conventional treatment with chemotherapy. There is a BioBran group here and the control group, and the endpoint was survival at 2 years. And you can clearly see that in the BioBran group, there is a 54.2% survival, while in the control group that didn't receive BioBran, there's only a 33.9% survival. And if you now look at subgroups, for example, patients with NK activity below 20% when starting this study, then you see a huge difference between patients with BioBran and patients who didn't receive BioBran. Namely, 42% survived 2 years of the BioBran group, and only 12% survived 2 years in the control group. This was published in Clinical Pharmacology in 1904. High numbers and activity of NK cells are certainly helpful for cancer patients, and we have seen this over and over again, that those patients simply do better if they have good NK cell function. This slide shows you our DC, dendritic cell vaccination program, in a schematic way. We start either with a simple blood withdrawal of 180 to 200 cc or with a procedure called leukapheresis, which takes blood out of the patients and gives the erythrocytes back but keeps the leukocytes, and monocytes are then collected from the buffer zone of the leukapheresis material, and those monocytes go into the laboratory. Then in the laboratory they are turning into immature DC cells. They can be primed at day 3 and day 5 of their development with either tumor material of the patient or proprietary polypeptide antigen that can be bought from certain cell banks. And after priming, they get the information of the specific tumor that the DC cells then shall communicate to the T cell system of the patient. In the end, we are giving back to the patient mature DC cells as a form of a DC vaccine. And that happens usually every month with a injection into the skin. We have another more personalized cancer vaccine program that is based on isolation of DNA from the tumor and from normal tissue of the patient. Based on the mutations of the tumor DNA compared with the normal tissue, which is analyzed by sequencing, we then try to produce a selection of peptides. They are synthesized by biochemists that will reflect those peptides that the mutations would create in the tumor cells of the patient. We use those peptides as vaccine and give a peptide mix with usually 10 to 20 peptides made in the laboratory back to the patient to create an immune response against his or her respective tumor. What can we now achieve with all this, and what is our experience with this protocol? Here I'll show you a 39-year-old patient with metastatic breast cancer from Jordan who had been diagnosed in 2004 with breast cancer and local regional lymph node metastases. Lumpectomy was done, lymphadenectomy was done, and adjuvant chemotherapy. 2 years later, multiple lung and bone lesions were diagnosed in that patient, and this slide shows you the PET scan of July 2006, where you see multiple black spots in the pleural area, in the axial skeleton, in the liver area, and the patient was found to have bone lesions, lung lesions, and pleural lesions. In September 2006, the patient was admitted to our hospital with breathlessness, tachycardia of 165 to 175 beats per minute, at rest, and cough. She was started on our protocol. Under the medication protocol and supportive measures, the patient's situation quickly improved. Breathlessness and tachycardia vanished. Cough declined significantly. In October 2006, we found pleural and pericardial effusion and a possible pericardial metastases. And I will show you this in the next 2 slides. Here, with 4-chamber view of the heart for this patient, we saw a 20 millimeter gap between the heart and the pericardium filled with water. In the front of the heart, there was an 18 millimeter gap. So there was a large pericardial effusion, and that was the reason that the patient's heart rate was still rather high at rest. We also saw a lesion, a solid lesion in the pericardium of the patient at that time. And you see here, that was on the 10th of October. 4 weeks later, we could bring this down without pericardial drainage to a 7 millimeter rim of water in the posterior pericardium sac and with no effusion in the front. And also the metastases is markedly decreased. Now, this patient had a pretty good run after she left our hospital. She had a good basis for a long-lasting tumor control. She was stable for the next almost 5 years on our oral medication protocol. However, in spring of 2011, the patient's tumor came back, for which she received chemotherapy in London. Unfortunately, the toxic effects of this chemotherapy protocol put her in multi-organ failure, and she died not because of her cancer, but because of chemotherapy. Now, this doesn't happen often. There's a 2 to 3% chance for that to happen, deaths due to treatment and not deaths due to disease. But for those who go through that, it's a sad and fatal event. This slide shows a 65-year-old male from Australia with prostate cancer that was diagnosed in September of 2004. In 2005, he received seed implantation and external beam radiation, two standard treatments for his disease. But bone metastases appeared 5 years later for this patient. And this next slide shows you the clear bone scan in July of 2010, and 5 months later it looked like this, with many metastases in the axial skeleton and in the rib cage. This patient was then starting on his own on our protocol in January of 2011, and he received dendritic cell vaccination treatment in 12 and doxycycline and salicylomycin treatment fighting cancer stem cells in May 15, and he had a wonderful treatment effect. Under our medication protocol, this patient had a wonderful run. His PSA reduced from 500 to 20 nanogram per milliliter within the first month. Then it declined to normal levels within the next 3 months, and it has stayed there ever since. This slide shows you the patient's PSA run. Today, 11 years after starting with our protocol, the patient's PSA is at 2.7 nanogram per milliliter, and his quality of life is excellent. Is his cancer gone? Probably not, but it seems well controlled under the protocol that he's on, and it behaves like a chronic disease rather than a deadly cancer. But let Tom tell you himself.
I had to tell my wife and brother that my oncologist had told me that my cancer had metastasized and that I had 18 months to live. I did things like meditation, changing my diet, leaving out sugar and carbohydrates, taking natural therapies like vitamin D, omega-3, magnesium, curcumin. At various times it held it, but then it'd go up again. Then it'd hold it, then it'd go up again. Hold it, go up again. Until I got to 543, when thankfully I got in contact with Ben, and the first month that I was on the therapy that Ben put me on, I went from 543 to 29.6. I told Ben that I wouldn't be here without him. You know, he's my hero. He's the one who saved my life.
Well, I don't know whether I indeed saved his life. It was him who did most of the work. And I think his cancer is still there, but it's very well controlled. And I wish Tom all the best for his future. But Tom is not one patient that could prove anything. That's why I have a slide for you with our clinical studies in men with metastatic and castration-resistant prostate cancer. We have 3 studies, 2 prospective and 1 larger one retrospective, and all kind of showed the same, namely that patients with metastatic disease have a good chance with this protocol to show a response, and that response is measured in PSA, the quality of life, and their survival time. In the year 2000, we had a very small study at the university I was working at. It was published in British Journal of Urology, and we had seen in those 16 men very few side effects only. We had another study done, much larger, a prospective study as well, at the Aeskulap clinic in Switzerland with a private sponsor, published in the Swiss Journal of Oncology in 2005. Here there was 174 patients who responded in a similar fashion like our small pilot trial, namely reduction of PSA, reduction of tumor volume, reduction of metastatic pain, and improvement of their quality of life. As for side effects, similar to the pilot study, some patients experienced libido and erection problems under the treatment protocol. Very few had dyspepsia in the first week of treatment. There was some reversible anemia of about half to 1 gram percent in 15% of the patients. And there was very few patients with thromboembolism events during the treatment protocol. We never know and still do not know whether this is a causative effect of the treatment protocol or simply the result of higher risk of thromboembolism in prostate cancer patients. This last row shows the results of a larger retrospective study that we started already with patients that entered our protocol in 2003. In 2014, we summarized all the data and we evaluated almost 500 patients. 388 of those men were still alive in 2014, and 28 of those survivors had the disease more than 12 years and were on the protocol more than 12 years. 8 had the disease more than 14 years and received our protocol, 2 more than 18 years, and 1 man more than 21 years with metastatic and hormone-resistant prostate cancer. We saw the same type of results with regard to PSA, tumor volume, and metastatic pain decline, and we saw the same spectrum of side effects. This is an attempt to compare survival benefit for metastatic prostate cancer patients through our protocol with existing treatment. And you see here 3 curves. One is the control curve with chemotherapy for patients with metastatic disease, and here in blue and the red curve you see the improvement of survival with second-line hormonal treatment and Provenge, which is a vaccination for patients with metastatic prostate cancer. When you compare those lines of conventional treatment, you see about a 6 to 8 months gain of time and survival for those patients. Superimposing our survival in the retrospective study, we have a much larger survival benefit for those patients. And this at a cost that is usually much lower than standard treatment. In conclusion, I would like to say that our integrative treatment approach, including specific phytotherapy, detoxification, antioxidation, anti-inflammation, and immune support, increases quality of life and survival of patients with metastatic breast cancer and castration-resistant prostate cancer. This last slide I have shown many times, but I like it, and I would like to share it also with you. This is a piece of medical history when physicians went on strike. In 1973, physicians in Israel go on strike for 1 month. Strangely enough, the number of burials decreases by 50%. This repeats in 1976. Physicians in Colombia go on strike for 2 months. And again, the number of burials decreases by 38%. And finally, in 1978, physicians in England go on strike for 1 month, and the number of burials here too decreases by 40%. Question is, should we physicians go on strike in the interest of our patients? This last slide will show you how to best get in touch with us. Last but not least, I would like to wish everybody of the Oncology Summit of Biomedica all the best. Stay safe and COVID-free. Bye-bye.